What MCL news is there? Well, I think the Ibrutinib data is probably the standout thing because it is the first time we've shown that using the drug earlier makes a huge difference to outcome. There's also some data on real-world experience with Ibrutinib. So Janssen ran a program where they gave drug to over 700 patients across 26 countries, I think. And looking at the outcome of that group of patients, purely based on how long the patients were receiving drug, it looks absolutely identical to clinical trial data. Now that's very important because usually when you have a new drug, when you put that drug from a trial population into the real population, the results aren't as good because they are, the trial population is very clearly defined. But here's evidence that actually in a non-trial population, the outcomes look comparable. So I guess that's not a surprise. It's a very well tolerated drug with few in the way of toxicities. So I guess that just shows in the real world what you see in a trial is what you get in reality. There's also some trial data, again from the UK, looking at frontline transplant, allogeneic transplant, not autologous transplant. Treatment of choice for young people is to give chemotherapy and then an autologous stem cell transplant. And there's some data here showing that if you do that, the Nordic approach, you are still getting relapses later on. I guess that's not a surprise. Nobody really thought that was curing anybody, and with longer follow-up of the Nordic data, again, which has been shown here, there are relapses happening. But an allogeneic transplant, somebody else into you, we've known for some time that cures patients, but of course it's a very toxic thing to do. So that tends to be reserved until later on in treatment, usually following an autologous transplant has failed. So we did a trial in the UK, 25 patients, frontline, doing an allogeneic transplant. And that was surprisingly good. The transplant-related mortality was only 8%, so treating people early on, obviously to get less toxicity. Progression-free survival, 3 years is about 70%, which is good. And the difference between an allogeneic transplant and an autologous transplant is that may well be very durable. So longer follow-up, we'll see whether that translates into better responses or more durable responses than you see with an autograft. You'd imagine it would. So you still have that chance of killing somebody. That's the trouble with an allograft. But I think what we're getting a better feel for is the bad patients. So we increasingly know which patients are going to do badly with conventional treatment. And I think what this trial shows is if you take those bad patients, then doing a frontline allogeneic transplant might be a smart thing. And I'm talking about patients with blastoid variant, patients that struggle to get into remission with high-dose cytarabine-based therapy, high-risk MIPI patients, for example. It's a distinct option to think about doing that as a frontline therapy. So that's, if you like, old-fashioned treatment in a modern world where everybody wants to give a BTK inhibitor, just reminding us that that still works.